Hi everyone. So the NEET exam is over, and as expected, it was a balanced paper. I mean, though the students are giving mixed reviews, some are saying a very tough paper, some are saying very easy paper. But as far as my understanding goes, the paper is broadly based on the things that we usually do in our internship, and that is how the things are going forward. I was pretty satisfied by looking at the way that the questions has been structured, and I feel that this is how actually the exam are gonna be. A lot of students are worried. They are talking about that what will be the cutoff and how it is gonna be. It is too difficult to predict the cutoff of an exam which has been given by more than or around 2 lakh students. But I feel that I recorded a video just before the exam by doing some mathematical calculation, and just on the basis of my assumption, I still feel that remains true. And if you are aiming for a rank between 1000 to 5000, a score of 600 is something that should be sufficient. Do not think that more than 1000 students is going to be more than 700. That is not going to happen. I know that a lot of people are saying on a Facebook and all. So for that, what we say that there are students who are saying that I am getting 820 also. So I mean, just ignore all those points. You people have done very well. As I always say, that just ask yourself that whether it was your best attempt, whether this is your satisfied attempt or not. Okay, so in this video I'll talk about some of the questions that have been asked from the radiology. As always, the questions of the radiology have been pretty simple. Most of the questions have been pretty well covered at all the places wherever that you have talked. So same with us also. I mean, everything has been properly covered. So now just see some quick questions. So this was a broad question. A 35-year-old patient presented with dull aching pain in the back and a sterile pyuria. So this was the statement that is written, sterile pyuria. We all know that one of an important feature of renal TB is sterile pyuria, and the radiograph was given. Now on a plain radiograph, if you see this, you know that this has to be either bone or stone. Obviously this cannot be bone, so this looks like a stone, but this is not taking a shape of a pelvic ileal system. If it is taking a shape of a pelvic ileal system, the answer would have been Stagon calculus. This is taking the shape of the kidney. So that means the kidney is calcified. And in renal TB, if the kidney is calcified, this is called as putty kidney. It looks like that it's a straightforward question from the notes. A worker who was working with hammer and chisel while he was trying to break a hard stone admitted to the hospital after injury to eye. Now this is a standard example that we give in the class, that a person is working with chisel and hammer. Now what has happened is that from the chisel a small iron particle has entered inside the eye. Now there is an important point that you need to remember. It is called as MRI. What is MRI? Metal results in injury. MRI, metal results in injury. So MRI should not be done in these patients. MRI should not be done in these patients. Why? Because if you will take these patients to do the MRI scanner, a torque will generate, and this foreign body will move and it can perforate the eye. Patient may turn blind. So the answer is MRI. Please remember, it is not the stone foreign body that is going in. It is the small tiny piece of the iron from the chisel that is going into the eye. Again, a pretty simple question. A 12-year-old child was admitted to the hospital with fever. There was some more clinical history was given. Now chest x-ray. Now chest x-ray classically shows this figure of 8 heart. Figure of 8 heart. Irrespective of where you have read, whether you have read with us or whether you read with somebody, I do not think somebody has missed this. This is a standard question that is asked in the exam. You know it's a figure of 8 or a snowman shaped heart seen in total anomalous pulmonary venous connection. Now for the next year, remember it is specifically supracardiac TAP PC. Okay. Now if you may get choices in the future as supracardiac, infracardiac, if it is specifically seen in supracardiac total anomalous pulmonary venous connection. Okay. In the given radiograph, the dilated bowel loops which are marked with the arrow represents. Now you could see this. Now there is a standard statement that we say that if you talk about the bowel loops, duodenum, specifically the proximal duodenum or a first part of the duodenum has cap-like appearance. Jejunum has concertina-like effect. Concertina, and ileum is featureless. So you could see this concertina-like effect. So this is standard, this is jejunal loop. This is jejunal loop. Next question. A patient met with a road traffic accident. In the casualty, he had a feeble pulse with pulse rate of 110 beats per minute. That means he is having tachycardia. There is reduced air entry on the left side. Systolic BP is 70. There is markedly reduced BP. That means he is having hypotension. So all these are pointing towards an unstable patient. So point to be noted, go back to the class notes. If it's an unstable patient after a road traffic accident, the patient should be operated as early as possible. If the facility of the ultrasound is available, we should perform a FAST, which is focus assessment by sonography in trauma. The aim is to identify the site of bleed so that you can plan your surgery in hand. If the patient is stable, CT is a preferred investigation. However, in an unstable patient, I do not want to waste my time and I would like to straight away proceed to the OT. Yes, if we can perform an investigation, I would go with FAST. So again, this was a straightforward question. Now, this is a standard question again. If you see this here, now a lot of students were asking us about that, can we give a breakup that how many questions are asked from a particular subject. So actually speaking, if I'm gonna start giving you a breakup, instead of 200 questions, you're gonna see 500 questions, because I will be claiming there are 22 questions from the radiology, pathologists will be claiming there will be 25 questions. Why? Because there was so much of the overlap. I mean, so much of the overlap. A question does not belong to one subject nowadays, and this is what you have to remember for the future exams, that nowadays the questions are being asked from the diseases, and a disease has got conglomeration of lot of subjects. That is what is happening. So now 10-year-old child presented with limb pain with normal bone mineralization. The mineralization is normal and the radiograph is shown below. So that's a classical, you could see Pelkan spur, you could see that proximal zone of rarefaction and Wimberger's ring. So these all are pointing towards scurvy. All are pointing towards scurvy. I'm deliberately not discussing the topics in detail. All have been taught to you in various classes across. So aim right now is just to give you the exact perspective, trying to get the exact choices so that you can get some confidence that the exam is not about hi-fi stuff. It is about these basic stuff that are asked in the exam, and you have to master this stuff if you want to get a rank in the exam. A 12-year-old child with a history of fever, headache and chronic ear discharge. Now, ear discharge with fever and headache, always think of an unsafe CSM which is going into the brain parenchyma. Okay, underwent a CT scan of the brain as shown below. What do we see? We are seeing a ring enhancing lesion in the brain parenchyma in the temporal lobe. We are seeing a ring enhancing lesion in the temporal lobe. So you have a diagnosis which is temporal lobe abscess. If it is cerebellar abscess, it would have been here. Extradural abscess would have been a convex margin, and meningitis will be seen as a shaggy leptomeningeal enhancement. So again, this was a straightforward image with a classical clinical history of abscess. Or a straightforward, I mean, if you have prepared for the exam, you cannot miss this particular question again, irrespective from where you have studied. So you have a clinical image, you have a typical subarticular expansile lytic lesion after the fusion of growth plate. There is only and only one diagnosis. You can mark it even in the sleep, and that is giant cell tumor. That is giant cell tumor. Now, what is the name of this investigation shown below, done in a female who presented with recurrent miscarriage? If you remember, we have spoken about it, that contrast studies is a favorite question that the examiner asks. Now, what do we see is the contrast is opacifying the uterine cavity. So if the contrast is opacifying the uterine cavity, it has to be HSG. It has to be a hysterosalpingography. On a background, you can see a radiograph. So if you are seeing the radiograph, it is a conventional HSG or a simply HSG. If I would have seen a CT scan on the background, it would have been a CT HSG. Saline infusion sonography is ultrasonography, and this is not an ultrasound image. So this is not the answer, and this is not a genitogram. So the answer is hysterosalpingogram. Next question. A 23-year-old female had a history of 2 stillbirth. Ultrasound revealed presence of a uterine anomaly. Which of the following investigation will be most useful in confirming the abnormality? I think we have spoken multiple times on this, that the best way to confirm a uterine abnormality is laparohysteroscopy. Laparohysteroscopy. Why? Because a laparoscopy will tell me an outer contour abnormality, like an arcuate uterus, and a hysteroscopy will tell me an inner contour abnormality, inner abnormalities like a septate uterus. A laparoscopy cannot tell me everything. A hysteroscopy cannot tell me everything. So if laparohysteroscopy is given in the choice, that is the best answer. Now in those questions where this is not given, the next best answer is MRI. So since this is given, this should be the answer, and the answer is laparohysteroscopy. Okay, so this was a controversial question. I'm not really sure that how the question has been structured. I have tried to speak to multiple students, some of them the one that who I assume will be in top 10 rank, but still I am still not able to get the perfect image. A patient presented with distended abdomen and the pain in the abdomen for past 4 days. See, this history plays a very important role, obviously along with the images. The student have told me that the 2 radiographs are given. Now please remember, if it's an X-ray abdomen erect and supine was given, or whether it's a lateral X-ray of the chest was given, mark my word, if the lateral chest X-ray of the thorax was given, the only answer that it could be has to be gastric valvulus. But a lot of students, including the one whom I assuming are gonna get the great ranks, they have told me that rather than the lateral X-ray of the chest, it was X-ray abdomen erect and supine was given. But then now the challenge is what kind of pain was given. Usually a perforation peritonitis or hollow viscous perforation will present with an acute pain. That does not mean that they cannot have a pain for 4 days. A gastric ulcer, usually the patient are having dull aching pain for the 3-4 days and suddenly it become very sharp, and that's a typical presentation. But all that you only know. I have not given the exam. I do not know what was the exact language of the question. If it's a history of 4-5 days, not a very severe pain, frontal and lateral radiograph was given, I am gonna go with the gastric valvulus. However, if history is given, pain for 4 days which have become sharp or which have increased, and an X-ray abdomen erect and supine was given, you are seeing air under the diaphragm, then it has to be hollow viscous perforation. Okay, as of now, going by this and going by the image that I am showing you, I will consider it as a hollow viscous perforation. But yes, if lateral X-ray is given, this is the history, I think gastric valvulus remains a possibility. Okay, this was a classical, I think we have discussed multiple times. A 5-year-old child felt difficulty in swallowing when he was playing alone unattended by the mother. I mean, a 3 to 5-year-old child develop something while playing, always think of a foreign body. So you are seeing a foreign body. Now only doubt that we have is it's a tracheal or an esophageal foreign body. If it has to go to the trachea, it will pass through vocal cord. So on a frontal radiograph, it will be like a slit. If you are seeing it end on a frontal radiograph, it should be an esophageal foreign body, and on a lateral radiograph, you could see the tracheal air clearly in front of the coin. So this is foreign body in the esophagus. I think it was a non-controversial, a straightforward question. This was another question. A patient presented with loss of the vision of the lateral side, something like related to the vision. MRI image shows an aneurysm compressing the optic chiasma. So if there is a compression of the optic chiasma, you know optic chiasma is present in the midline. Now obviously it has to be an aneurysm originating from the vessel that is present right into the midline. So you know that you have got 2 internal carotid arteries. They bifurcate into the MCA and anteriorly they give ACA. The 2 are joined in the midline by anterior communicating artery. So if there is an aneurysm from the anterior communicating artery, it can compress optic chiasma. So according to me, the most appropriate answer for this question should be ACOM aneurysm. A child is suffering from ALL. He has undergone prophylactic cranial radiation for the same while waiting for bone marrow transplant. Which of the following will be least affected by radiation exposure? So rather than, if this is not given, only if you read this line, it says among these 4 which is least sensitive to radiation. I think those who have studied with us, they remember this is the chart that we always say that you have to revise 1 day before the exam. The tissue which is least sensitive to radiation is neurons, because they are highly differentiated, and if cell which is more differentiated, it is less likely to be affected by the radiation. So the answer is neurons. Bone marrow, spermatogonia, intestinal mucosa, these are the one that are more affected by the radiation because these are radiation sensitive areas. This was one question. I do not know why some of the students did it wrong. This was a standard thing that has been taught. It's an ortho radio anatomy mix question that has been taught. Spine. See what are the important salient features that were given in this question. I probably will be needing your help. You can put it into the comment section if there is a change in the language of the question. A child was brought to the hospital by his father with complaint of fever, low backache and persistent flexion of the hip joint. He had a history of spine TB in the past. Now this is a standard thing that has been taught to us. In fact, when we were interns, that persistent flexion in a patient who had a spine TB, the first thing that you should think is psoas abscess. The first thing that you should think is psoas abscess. On examination, child has some query inguinal swelling. One of the students told me that some swelling was mentioned. I do not know what was they trying to mention, but it could be that the abscess is trickling down. Identify the marked muscle responsible for that. So this was the muscle that was marked, and this is nothing but psoas major muscle. Psoas major muscle. So please remember, history of spinal TB, the examiner is trying to tell you that there was a spine TB and now the patient is presented with a flexion deformity. That means the patient is developed psoas abscess. So the answer should be psoas muscle. I mean, obviously, if I change the language of the question, it could be, it could be anything. But on the basis of the language that I have got, I feel that this should be the answer. A 45-year-old male presented with back pain and morning stiffness lasting for more than 30 minutes since last 2 years, along with redness of the eye. Redness of the eye is pointing towards uveitis in this case, and the patient has got morning stiffness, and a radiograph was given. I'm not sure whether the radiograph of the pelvis was given or the radiograph was the spine was given, but there was fusion of sacroiliac joint and as well as the oncovertebral joint and bamboo spine was given. So if you have bamboo spine, even if you do not know anything about the history, you know it is ankylosing spondylitis. I mean, it was again a straightforward question. Now this was a pretty interesting question. A 63-year-old hypertensive patient presented with chest pain and diaphoresis. On examination, he has unequal pulses in both arms. Which of the following is the most useful imaging investigation in emergency in this case? Now, if you remember, when we speak about ultrasound and I tell you the advantages of the ultrasound, I say one of an important advantage of ultrasound is its portability. And because it is portability, time is money. And because it is portable, this is the standard example that I give you, that this is a case of aortic dissection. This is a case of aortic dissection and unstable patient. Any patient in aortic dissection who is stable, I would like to go with a CT scan to look at the way that the dissection has been progressed. However, any patient of aortic dissection who is unstable, I do not have time. I would like to take the patient to the OT. The only investigation that can be performed is the one that is portable, and the single best answer over here is TEE, transesophageal echocardiography. Transesophageal echocardiography. So this was a question which was more related to the surgery. The surgery faculty is gonna give you a much better answer for that. A 55-year-old chronic smoker presented with pain in the thigh and the angiography was done and shown below. So there was an angiographic image that was shown. Now I was unable to get what was the exact angiographic image, but it's a simple concept. Now whatever the angiography, wherever was the block, if the block was here, you will have to do the bypass like this. If the block was down, obviously, so basically you have to do a bypass in a way, wherever is a block, it should circumvent that bypass. If the block was very short segment, you could stent also. I mean, that totally depends on the exact angiographic image, where was the exact block. If it was a diffuse block, obviously you have to do a bypass accordingly. Okay, so these are the broad questions that I feel were linked to the radiology. My expectation with the paper, as I say, that's a pretty balanced paper. If I just do a bifurcation about this, I feel that out of 200 questions, 120 questions were pretty easy, very easy. Around 10 to 15 questions were broadly undoable. Previously we used to have slightly bigger number. Around 10 to 15 questions were undoable. So all the game is with this 65 to 70 questions. All the ranks are totally based on these 65 to 70 questions, that how many you did right. So it was not a paper, from my side, it was not a paper of 200 questions. It was a paper of 65 to 70 questions. how many questions you are able to hold your nerve. Okay, I expect that the topper will be having marks or will be doing at least 175 to 185 correct. If you are aiming for a rank in top 10, that is what I feel. If you are aiming a rank within 5000, I feel that 600 is a reasonable score. If you are getting a score close to 600, you are in a safe zone. You are definitely getting a clinical seat. Even up to 550, you are getting a clinical seat. If you are going below 500, the chances of getting a government clinical seat becomes remote, and the qualification, as I made in my own other video, is gonna be somewhere between 250 to 275. That's all. So that is all. Thank you very much for all your support that you had with us, and do let us know if we can do anything else for you. Okay, take care and wish you all the best for the result.